Dr. Stephen Rakes is currently an associate professor with the Department of Urology in the Levine Cancer Institute at the Carolinas Healthcare System in Charlotte. And then our second speaker is going to be Mary Dunn. Mary is a nurse practitioner at UNC Chapel Hill. She works in a multidisciplinary role within urology and medical oncology, caring for patients with genital urinary malignancies. In this program about proactive patients, we're going to discuss tips on how to be a proactive patient. We'll provide some suggestions of questions to ask, including the following key topics: how to prepare for meetings with medical professionals, how patients can improve their chances of getting the best treatment. We'll talk a little bit about the value of a second opinion, and what questions to ask about the procedures or treatment options. And we're going to point out where you can educate yourself and who and what to bring with you.
Well, what I've been tasked to do is just to really look at this from the physician's perspective, and the things that I think help patients to get the most out of their appointment are really going to tout around a central theme, and that is preparation. I'm a firm believer that the more a patient comes in prepared and seeks information and then looks for opportunities after the appointment to gain further information, that they're going to become engaged. An engaged party along with the physician, and certainly at the end of the day, we're trying to help patients become informed decision makers. So I think the first and foremost thing is to familiarize yourself with the concepts of medical terms. A great place to start off with that is the BCAN website, but also just kind of looking up general concepts on bladder cancer and understanding some of the terminology. And then I always encourage people to write down a couple questions, because, listen, the visit itself becomes very anxiety-provoking for the patient, and I think the folks often come in with a lot of uncertainty, a lot of preconceived ideas about what is going on, about what is happening to them, and sometimes you can lose focus on the agenda of what you're trying to get done. So bring questions that really helps you form your agenda of what you want to accomplish during the visit, and then you hopefully allow that to parlay into a collaborative effort with your treating physician. I was encouraging to give to the nurse ahead of time. I will tell you it's a well-known fact that the nurses prompt their physicians, the staff prompt their physicians. That happens with me all the time. And so when you articulate specific concerns or needs to the nurses, often they will be articulated to the physicians, and you're just trying to, again, be proactive in setting up the appointment / visit to get out of it what you need to. Take notes. I always encourage people to bring somebody with them. I think the person with the disease, because it's such a stressful situation and because there's such uncertainty, especially at first, that it's really hard to synthesize all the information that's coming out to you. And I think you have to be realistic about upfront about what you can get out of appointment. I will say you can't learn everything. We can't teach you to be an expert in bladder cancer at one appointment, nor at 10 appointments, but if you can learn a little bit each time and slowly but surely enter into that space, then you become more informed and better to make decisions on your behalf, and clearly discuss that with your physician. But again, bringing somebody to help you synthesize that information and what they heard from a uninvolved, unbiased participant, I believe, is very important. I think things you want to think about and understand are the staging and kind of figuring out what that means, where you are, is that even applicable to you yet, the treatment plan. And when you really discuss treatment plan, things about, hey, is this going to work? What's the chance that things get worse? What's the outlook for me? I think the other thing that's important for people or patients is to understand the names of the personnel. If you're seeing a particular urologist, if you know who moves the needle for them, who are their nurses, who are their nursing assistants or LPNs, the names of those people will take you very far in any appointment, because when you call back or when you're looking for answers, if you know names, if you can relate back to them, then there's a much better chance that you're going to get the response / attention that you need. And you got to remember that often for many people in physicians' offices, everyone's important, but there's a lot of patients, and there's a lot to be done each day, and you want to start to get a sense of how to navigate the system. And then I added this final bullet, and I didn't have this the last time we did it, but I think this is becoming more important and more relevant. I find it very important for people to understand how the physician and staff want to communicate. There's a lot of electronic medical records now that communicate by email, and it's hard-pressed to find systems that don't do this. But if that's the way that they communicate, and that's the way that they prefer to communicate, and that's the way that's articulated to you that you will get a response, then that's a good way to follow up, to ask questions, to begin to kind of figure out the way to understand how to communicate with your physician and staff. Some physicians like to communicate by cell. I have a lot of patients that personally text me. I'm not saying that that's what a lot of people do, and I'm not advocating that that's the appropriate way, but it just depends on the dynamic of the physician and the patient and their staff. So I think you need to ask these questions and then be clear about how that is so that you can move forward. Because it's likely that if you are a proactive patient, it's likely that you will have questions, and again, understanding that you can't take all the information down in one setting, and so this is an iterative process, and that iterative process for the patient is to slowly but surely understand where they are and where they're going. So a couple other things, and I think this speaks to the concept of, are you in the right place, and being a proactive patient, am I understanding that do I feel like the physician is competent in what he's doing, and am I getting good and right information? And so I would just say off the top of the head, if they start talking to you about resources and different options of where you go, then you start to get some insight that this is a place that treating physician has been in before. And so strictly related to if you have to have your bladder taken out. You know, I think it's very fair. I often chuckle when patients ask me, they often preface that, hey, I hate to ask this to you, or I'm a little uncomfortable asking this to you about how many of these surgeries do I specifically do, and what are my outcomes, and how do they relate to national standards. I don't think any physician feels turned off by that. Any surgeon feels turned off by that. I think they expect that question. I think you should ask it, and I think what you get back is not just the answer to how they do it, but an understanding of how often they do it. It's just truly something that's in their niche, because most folks who spend a lot of time in this space should be able to easily articulate this back, and also most places who spend a lot of time in this space tend to track their outcomes and know how they compare to nationally, and are iteratively trying to improve on those outcomes. So I think that's a really important question, and you should feel comfortable in that space asking that. Just some other questions I asked, and this that I put on the slide here, and this really just gets to, hey, I've prepped for the visit. If I think I'm going to have my bladder taken out because that's what I believe is going to happen, or this is further down the line, things you want to, again, in prepping, and as you learn more, is you perform it laparoscopically or open, is there differences in these, and then engaging in a more quality of life type discussion, and then, you know, why would someone choose one option versus the other, and what does this mean in terms of quality of life for me? Because at the end of the day, that's an important consideration. The hope for all of us is that we can treat folks and return them to their environment, but certainly the long-term outcomes and the toxicities that they might incur need to be thought of in a longitudinal fashion. So addressing those early on and understanding not only, hey, we're trying to cure the cancer, but what else does that mean, and engaging a physician in your desires and what's important to you is really important to your surgeon and physician in terms of making decisions. The other thing that I think is important is that any surgeon should, if for people that have muscle invasive bladder cancer that's talking about having their bladder removed, you should understand, and they should quickly articulate to you that there are other ways than just removal of the bladder. Doesn't mean it's right for you, but not everyone who walks into into a urologist's office who is told they need to have the bladder out wants to do that, and there are other options, and I've listed those down there. And again, I think that speaks to some world retrieval and some preparation and some working around consistently and steadily around your disease state and where you are to help ask those appropriate questions. And then again, around non-muscle invasive, if that's what you're there for, the concept, there's a lot of permeation of the concept of repeating a bladder scraping or transurethral resection, and certainly engaging your physician in that question and posing that, I think, is very important. And if you are at that level, then I think you should say, hey, I'm starting to get a grasp on where I am and kind of the general concepts. And then we use a lot of intravesical or in the bladder therapies after treatment of bladder cancer that has not yet invaded into the muscle. And then there's multiple types in those, inquiring about those. How are they given? Where are they given? If you're traveling a distance to see someone, can these be given in a more local setting? Because that could be disruptive. And then certainly understanding what that schedule looks like and asking for that schedule. Oftentimes, in some spaces, we give these medicines out to 3 years. It can be a little bit confusing. I know personally we give a very detailed schedule so the patient can proactively mark it off for themselves. And so I think, again, understanding where you are, where you want to be, and where you're going are important things to consider and ask. So I think other things that start to get it to speak to the concept of, hey, is this somewhere that I want to be treated? Is as an institution, how often do you do it? Again, as an institution, what are your outcomes and complications? And then getting into the concept of clinical trials, most places that deal with a lot of bladder cancer certainly understand and participate in clinical trials, and not only ones that they have locally, but also ones that are not locally that may be applicable to you, and certainly understanding on a more global scale that the Beacon is really, organizations really worked hard for patients to help understand, but certainly that should be part of the discussion with your physician, or at least a broaching of is that applicable to you at your current disease state. So specifically going on a little bit more distant cystectomy, I'm a big advocate of this. I think the concept of bladder removal and then how you're going to get your urine out after is a very, very dense subject. And so I always tell people, and then I think it's very important to separate that out. Number one, to decide if you're going to have your bladder removal, and then regroup after you've made that decision to what are the type of diversions, meaning what are the type of ways to get your urine out, and what is right for you, and having a discussion. I actually find that to tell people that the discussion for me and the patient appears to be better when I give them some information about the different types of diversions, or that they go out and understand the different types of diversions from their own research and then come back and ask questions. It's really hard to put that in perspective when you have no weapons in your bag to understand what that even means or what you're even thinking about. So I would encourage you, if you haven't prepared for that and you're just trying to decide about bladder removal, that you then engage in a follow-up appointment, which most people do, and come back and then have a second visit where you just talk about the type of diversion. And again, I just put that last bullet. I will tell you, just on that perspective, I think people come in with a lot of preconceived notions about the type of diversion they want, and they're often rooted in not inappropriate reasons, but unrealized reasons in terms of what that really means for them. And there's a lot of things that we have to help them with, kind of understand what one diversion means for them, and what are the pros and cons or pluses and minuses of any diversion. So I think that's needs to be a very focused and collaborative discussion. And then bladder cancer, we believe, or I believe, is a very multidisciplinary disease, as well as is most cancers these days, and that's just not the collaboration between a surgical and medical oncologist. That's the collaboration between a surgeon and a radiation oncologist, between a surgeon and a a psychiatrist, a social worker, somebody who can deal with the anxiety and the mental part of cancer, to survivorship, to nurse navigation, to a lot of resources that people need. So when I think multidisciplinary, I think what are the resources and people on the team to treat the entire spectrum. But certainly medical oncologists and radiation oncologists from a treatment provider are two of the big additional physicians that are often engaged in this disease state. And then I think the other question is second opinion. When people ask me should they get a second opinion, I always say yes, and I followed up with this. I get a lot of patients that come to me for a second opinion, and I think any physician would say to you, or hopefully say to you, listen, at the end of the day, this is not about me. This is not my treatment decision. I often, most every urologist you're going to talk to or urologic oncologist that you talk to has not had their bladder out. They have not had bladder cancer, so they are not walking in the same boat as you are. And you need to, at the end of the day, do what you feel most comfortable. And if you feel uncomfortable, you need to spend the time to get the right information to make you comfortable and at least confident to make a decision that you feel is good for you and your family. So second opinion, I think, is never a bad idea. I'm not saying you always need it, but it's never an idea. And I always tell people who call me up that, listen, if your gut's telling you should get a second opinion, then you probably should. So I think I touched on a little bit about this. I think the other thing is finding patients. The Beacon's done a very nice job of this, of connecting people with other patients. They've done a fantastic job. I think this is one of the greatest resources they have. I know we personally keep our own list, and I think the nice thing about a local level patient, if you can attain it, is just what that process means in that system that you are in. What does it look like in that environment, not in the environment that someone else went through? So I think seeking that out and asking for that resource is really important, because they can really identify with you where you are on all fronts. And then again, I touched on the additional support and the services that might be of benefit and things that I would recommend seeking out, again, in that concept of multidisciplinary, extending beyond just treatment providers. But what are the other resources for you as a patient and your family or significant others? These are some of the Beacon educational materials on the website. Again, it's just littered with fantastic resources. I spent a lot of time, I'll tell you a quick side note, I spent a lot of time putting together a whole information pack on bladder cancer. We hired an artist, we did all this stuff over 2 years, and it's compared to what Beacon has, it really is not as good, and they've just put so many resources and so much effort. And I think if you just said, hey, what do I have to do before I go in the visit, I think you need to download the one easy thing is just to download the book, the packet information booklet, and start reading that or looking through that to prepare you is an excellent way to start.